Welcome, everyone. You are here for Chronic Kidney Disease Structured Collaborative Session 6, also known as the last session together, sadly. And we are going to be having everything you need to know in a call to action today with Dr. Campbell. I'm your host. I'm Mary Funseth. I am from Metastar, which is a partner within Superior Health, and we are here in Wisconsin. I'm a social worker. Now, let's go around the room and introduce ourselves, and if you'd let us know also your position. So I will call each person as I see them on my screen. I'm going to start with Diane.
Good afternoon, everyone. My name is Diane Carlson. I'm Executive Director of Midwest Kidney Network. It's a pleasure to discuss early identification and treatment for people who have kidney disease. Thanks for the opportunity to join.
Thanks, Diane. Janelle.
Good afternoon. My name is Janelle Gagne. I'm a clinical dietitian. I've worked in the area of nephrology for 33 years now. I've worked with all modalities and pre-dialysis as well, and I'm glad to be here.
Thank you, Janelle. Amber. And Amber, you're on mute, but if you want to chat it in, you may do that as well.
Are you able to hear me?
Yes, we are. Welcome, Amber.
Perfect. Thank you. Thank you. I am the clinical manager here at Avera Dialysis in Sioux Falls. I think you've met my pal, Patrick. He is the manager for our regional dialysis units. He's not able to join today, so I'm going to be joining. I've been in dialysis for about 17 years now, the majority of my nursing career.
Great. Thanks for joining us, Amber. We're excited to have you. All right, let's see who's next. My screen. Let's go to Dr. Campbell.
Good afternoon, everyone. Thank you all for inviting me. I'm Dr. Orville Campbell. I've been a nephrologist for over 26 years. I trained at Emory University for internal medicine and nephrology. I've had lots of years of experience also in UR, and in the correctional healthcare space. I currently serve in the role of Vice President for New Business Development and Strategy for MPRO.
Thank you very much. And Jerry.
Hi, my name is Jerry Henniker. I'm a registered nurse. I work at Stratus Health, which is the QIO in Minnesota that is part of the Superior Health Quality Alliance. And I just have to give a shout out to Amber because I grew up in Southwest Minnesota. So, you know, Sioux Falls was always our stomping ground for the big city to go shopping in.
Great. It's nice to have that familiarity. All right, so next what we're going to do is we're just going to do a quick debrief on session 5. And I'm going to assume, Amber, you probably weren't a part of that particular action plan. So we're going to have Dr. Campbell just explain just a little bit about, you know, what the action plan could entail and the importance of it. Because as we look at future opportunities for folks to view this, we're hoping that people will consider using the action plan suggested as something to do within your system. So Dr. Campbell. And you're on mute.
Always.
There you go.
You're referring to the action plan for session 5, is that correct?
Yes, yep.
Okay, to choose one of the educational resources provided in session 5, using the resource practice, the teach back technique. I just want to be sure I explained that correctly. That's an example. Can you tell me or instruct me what you heard me say about whatever that clinical scenario is or direction? And if someone can explain it to you, then they truly grasp it. Not sure if anyone in the audience have used that or plan to use that or continue to use that, but it's a very effective tool in ensuring that the patient has heard you, They have listened to you. They have comprehended. Now that they can repeat and actually instruct you that they understand.
Thank you. We can go back and ask questions about that in a bit. And today's objectives are to provide important takeaways from this collaborative by kind of looking at each session. We're going to be sharing lessons learned and actions to put into practice, as we kind of just mentioned. And then we're going to talk a little bit about the call to action and next steps that folks should consider as they review this information and as they look at their practice to help with CKD. So next, Jenna, if you'll launch our poll, please. Okay, so the poll, we see the end poll. Okay, so it caught up, sorry. Okay, great. So yes, KDIGO is a nonprofit organization, global nonprofit organization that is helping us develop evidence-based practices and guidelines. It's something that I wasn't aware of until one of our speakers brought it to our attention. And hopefully all of our participants from this will go out and look at KDIGO. We'll definitely make sure we put the website in the chat. Jerry, if you don't mind doing that in the next, in our next period of time here. But it has a wealth of information. And from what I understand from our presenter who brought this to us early on, she basically said there was a lot of providers that absolutely did not know about KDIGO. So we hope that all of you will go out and take a look at it. So next, we're going to just move right into our look at the sessions, and Dr. Campbell is going to be our moderator and teacher for that. So I'll hand it over to you, Dr. Campbell.
Thank you, Mary. Moderator is the exact word, not a lecturer. Please feel free to interrupt me. This is a takeaway session. We want to make sure that the takeaways are both relevant and clear to everyone. So session one talked about how 15% of America's population has CKD, and the majority of those individuals are unaware that they do have CKD or chronic kidney disease. All right, we should know who should be screened for CKD. We'll talk about risk factors for CKD in the upcoming slides. We talked about KDIGO, which stands for Kidney Disease Improving Global Outcomes. It is a nonprofit organization that's international or global, and it's instrumental in developing and implementing evidence-based clinical practice guidelines involving kidney disease. We do need to understand the definition and classification of CKD. And also we need to understand the tools that we use that diagnose or monitor CKD. It's important to know that creatinine alone is not adequate enough. It's not sufficient enough. It's not robust and comprehensive enough. Just using creatinine is saying, well, because it's sunny, it must be 85 degrees because it's it must be August or the summer. No, it could be sunny and be 20 degrees. So it's important to know that you can't just look at the creatinine and get a context for chronic kidney disease. The race modifier for African Americans used to estimate GFR or glomerular filtration rate, which is a measurement of kidney function that uses serum creatinine, is, well, it has been eliminated, and there has been advice from the American Association of Nephrology to go ahead and eliminate race from estimating GFR. Next slide. So that was the takeaway. Those were the takeaways from session 1. Now, session 2 involved talking about the 5 stages of CKD, and there are 5, 1 being mild, 5 being severe or end stage, and then in between there are the other stages. It's important that when we look at the stages, that our treatment plan is going to be different for each stage. It's going to be totally different from stage 1, 3, or 5. Most people who are at stage 5 do need some type of renal replacement therapy, be it hemodialysis or peritoneal dialysis, but they do need some type of renal replacement therapy. Keep in mind, end-stage renal disease doesn't necessarily mean that you have no urinary output. So it's important to know that morbidity and mortality is tied to the ability to produce some urine. So we want to be cognizant in the way we approach the treatment and of end-stage renal disease, that we don't use nephrotoxic agents that would get rid of the ability to pass urine. It's important for us to know the key screening tools that we'll talk about in an upcoming slide. And it's always, no matter what disease process you talk about, always know that a robust history and physical is the first place to start. And always listen to the patient, because we know that if we stop talking long enough, the patient will tell us what's wrong with them. No amount of technology can compensate for a comprehensive, robust, and adequate physical exam. The signs are there, whether it's the color of the skin, whether certain rashes, or even the patient's breath can tell you a lot about the patient's disease. Next slide, please. Session 2, remember I said we looked at risk factors. It's so important to know that there's so many risk factors, so we have to pay attention. I won't read all of them, but certainly some of the major ones are, of course, type 1 or type 2 diabetes and hypertension. The importance of controlling those 2 diseases, especially diabetes, is the #1 cause for loss of kidney function in this country, the USA, and hypertension is second. However, if you look racially, hypertension is #1 for African Americans, followed by type 2 diabetes. Native Americans would be diabetes as the others in the general population. It's important to realize cardiovascular disease, what happens to the heart blood vessels happens also to the kidney blood vessels. So that's important to know. Obesity, it's important to know that the more above your ideal body weight you are, the more the kidneys have to work, which puts you at risk for chronic kidney disease. Know that race, U.S. ethnic minority status, especially African American, Hispanics, Asians, Pacific Islanders, and American Indians are at greater risk. Some of that is tied to cultural competence in the delivery of healthcare, access to healthcare, stereotypes, even in the medications we choose to use. And also know that inappropriate use of certain medications can do that, as well as structural damage to the kidney or acute kidney injury. Next slide. Session 3, management of early CKD. We do have to be aggressive in the control of hypertension, aiming for blood pressure less than 130/80 in patients with existing CKD, especially as it relates to proteinuria or even albuminuria. may not be frank proteinuria or even nephrotic range proteinuria. Any significant albuminuria is cause for someone with hypertension and CKD for us to target less than 130/80. The use of ACE inhibitors as well as ARBs, that's really important to know. Certain diabetic drugs for type 2 diabetes, such as SGLT2 inhibitors, are both cardioprotective as well as renal protective, all right? And it has been shown that if you're over 50 with CKD, regardless of your lipid profile, you can, it's renal protective to be on a statin. So some people may say, yes, I'm over 50 and yes, I do have chronic kidney disease, but I have a normal kidney profile, or lipid profile. It's very important to know you will benefit from a statin. Treatment of acidosis, metabolic that is, because you can have respiratory, but metabolic acidosis, and treatment of sleep apnea can prevent the progression of CKD. It's really important to know that sleep apnea is very common and puts individual in a hypoxic state, which is a risk factor for vascular disease. And again, the kidney is rich with blood vessels, so it's very important to note that sleep apnea, although you don't have diabetes or hypertension or structural kidney disease, puts you at risk for developing CKD and certainly its progression if you do have CKD. High-risk medications should be avoided, and many other medications that are safe in CKD still need to be adjusted. Medications that are high risk include non-steroidal anti-inflammatory drugs. Next slide. Session 4, medical nutrition therapy for chronic kidney disease. People with CKD who receive medical nutrition therapy or MNT will demonstrate less of a decline in their GFR or kidney function and achieve better outcomes. Again, nutrition therapy is tied to delivery of good nutrition, including minerals and vitamins, to the kidneys, which overall will improve tissue nutrition and therefore will lessen the chance of a damage to the kidneys or progression due to disease state. Things like antioxidants, foods that increase nitric oxide to the body will feed tissues with a higher oxygen levels. It's really important to know that although a lot of us are interested in antioxidants for overall body function, know fully well that includes the kidneys as well. What are antioxidants? Those are those highly nutritious components that you really can see. For example, when you look at bell peppers, the deep red or green colors, when you look at carrots, the high and bright orange color, those are antioxidants that you're looking at. Medical nutrition therapy is most effective when provided at very early stages, where the goal is to manage comorbidities in order to protect the kidneys from damage or progression of disease. It's important to know early intervention, especially prevention, so you don't have to intervene, is always superior than treating advanced kidney disease or any disease for that matter. So key management strategy involves lifestyle modification and then includes dietary modification. Dietary modification is not just a list of do's and don'ts to the point where the patient exclaims to you, well, what in the world can I eat? You've just listed a whole bunch of things I can't. So what I tell people to do, consider portion control and consider counting things rather than eliminating things. If you're concerned about potassium modification in the diet, don't say you can't have apples, you can't have bananas, you can't have mangoes, you can't. If you're going to have an orange, for example, then don't eat the banana as well. If you're going to have a sandwich, rather than doing 2-3 slices of tomatoes, consider 1.5 slices. When it comes to phosphorus, rather than say you can't drink milk, let's look at some milk alternatives and let's look at, well, how much liquid can I have when it comes to milk? Let's develop substitutions, portion control, modification, and not just exclusions, all right? Activity, physical activity. When people think modification of lifestyle involving physical activity, a lot of times they think I have to go to a gym, I have to spend money in a gym. Keep moving, all right? If you're working, consider a standing desk where you can stand for a couple of hours out of the day if you have the energy. Take 2 flights of stairs. If you can do one, do that. Just keep moving. Take your lunchtime. If you have a half an hour, take 5 minutes for a brisk walk. If you cannot do brisk, just walk at your own pace. Just keep moving. That's what it's all about. Anything that's stagnant, even water. If you see stuff growing on water, it's because it's stagnant and not moving. Medical nutrition therapy focuses on healthy eating patterns, inclusive of plant-based protein. Plant-based proteins are really good. For example, I had a patient that was a vegan and on dialysis, but we talked about using plant-based protein. And that patient always, despite being vegan, always maintained a great albumin level, usually above 3.8. So know fully well, gluten, for example, that some meat substitutes are made of, or just using the natural plants that have gluten can be a rich source of protein. Adequate fruit and vegetable intake for balanced diet, and decrease consumption of fried and processed foods. Remember, when we use processed foods, the preservatives, for example, the body does not recognize a lot of those preservatives naturally. So what does the body do? The body tends to gain weight because the body says, you know what? I don't know if I can really extract nutrition from this chemical that I'm seeing in this honey bun or whatever. So you know what? I'm going to go into storage mode. And so people tend to gain weight. That's one of the reasons when you eat overly processed foods, and some foods do need to be processed, overly processed foods with preservatives, that's why you tend to gain weight. Another reason is because those overly processed foods tend to be highly caloric in content. Individualized nutrition action plans. Let me repeat that. Individualized. I didn't say cookie cut. Say individualized nutrition action plans are desperately necessary to ensure compliance or adherence to our recommendations. And remember, our recommendations need to be sensitive to socioeconomic factors. Don't recommend salmon if patients can only eat chicken. It's very important to know the socioeconomic status of a patient. And it's also important to know the spiritual or religious background of the patient. So we can't recommend pork to everyone based on certain thing. If we're dealing with Seventh-day Adventists or the Jewish community, know that the fish options can't be catfish. It has to be something with fins or scales. So one of the things that I've given to some of my patients who are Jewish or Seventh-day Adventists or of similar faith is there is I can't remember the website, but I use it when I go on vacation. I use it a lot in Hawaii because a lot of their fish names do not concur or not congruent with the mainland. So I have to look it up. Does it have fins or scales? Oh, yes, I can eat that. And I say, yes, a server, I can order that. All right. Ongoing monitoring by a registered dietitian is certainly highly advised to assist patients in meeting their goals, avoiding consequences of malnutrition that occur, especially in the later phases or stages of CKD. The more you go down in the CKD depth or later stages, the more individuals will lose the ability to taste. Sometimes they say, I have a metallic taste, and sometimes their appetite will be blunted. So as you lose kidney function, it can become challenging. Some foods are better taste than the others, so it's important to work with the patient to ensure their likes and dislikes are known. You can recommend something till the cows come home, but if the patient hates it, it's just a fruitless exercise to recommend that. All right, next slide. So session 5, we talked about CKD education and support resources for patients and care partners. And go back to that slide. Care partners. You have to realize that patients need support, not just physical support, but emotional support. So it's important that for accountability purposes too, and just for emotional and physical support, the care partners need to know what the plan is for the medical issues as well as for the dietary issues. A lot of time, one partner does not cook and the other one has to. So therefore, it's important for those partners to be on the same page in preparation of food. All right, next slide, please. It's important to know repetition does improve patient learning and retention. 7 times is sort of the number I want you all to keep in mind. For example, salespeople that call on you. Remember prior to COVID when you would have sales representatives, whether it's pharmaceutical and others, you know how many times they would target physicians or anyone in that office? 7 times. Because 7 times is the magic number for people to change their thinking and for learning to be received really in a very impactful way. So repetition does improve learning and retention. Patient education is more effective before the patient has advanced disease. And in the case of CKD, uremic symptoms where comprehension can be severely impacted because of the waste products or these uremic products. It gives their thinking a foggy side effect, and they may not comprehend, they may not be able to recall things. So it's important for us to know our educational tools should include how patients can document and their caretaker can document things that they will be able to recall later based on its written or documented format. All right. I'll pause at this time. Are there any questions or are there any comments in the chat or questions in the chat? We'll go back to that slide. Yes, just hold for that slide. I'm just going to pause here to see if anyone has any questions in the chat.
I'm not seeing any questions in chat. So I mean, people, if you want, you can put your questions in chat, or you also
comments.
Or
comments.
Jerry's added a ton of comments. And so I think I found your list of kosher fish, Dr. Campbell. So I put that
Beautiful.
But I'm not seeing any other comments. I just was kind of trying to keep up and was adding stuff in to chat as you were speaking. So
beautiful. That list of kosher fish is very important for people of certain faiths. And that's one resource that I've always shared and so on. Individuals who are Jehovah's Witness, for example, we know they will not take blood transfusion. So it's important that we pay more attention to their iron status and the iron in their diet and epogen. Now, some will not accept epogen. Most will, but some are a little uncomfortable, so even more. And as a nephrologist that has taken care of a lot of Jehovah's Witness patients, because when they realize you will respect their faith, then they will make recommendations to come to see you. And it's very important. And it's very interesting that you could keep patients on dialysis for 10, 15 years, and they do not need a blood transfusion. Now, while that is certainly necessary at times, but it tells us we can do a whole lot better in the dietary instruction and in giving IV and oral iron. IV iron is perhaps better when it comes to patients that are on hemodialysis, but those individuals that are not on hemodialysis, certainly a good iron supplement in concert with a diet rich in iron is extremely important, right? GFR less than 60, patients are at higher risk for cognitive impairment, not because they're uremic, but they're not getting rid of all of their toxins. And a GFR of less than 60, that they still retain a lot of kidney function, but the thinking can be foggy. It's very important. Also, it's very important to note when the GFR goes below 60, that's when you start to see bone mineral metabolism go south, secondary hyperparathyroidism. In other words, the liver and the kidneys are both responsible for activating vitamin D. The process starts in the skin, but when you do give D3 or D2, the kidney is instrumental in the last step in activation of vitamin D. So if your kidneys are sick or not up to par in terms of the stage, then you're going to experience vitamin D deficiency, and you're going to experience hypocalcemia or low calcium or lower calcium levels. So what happens? The body responds by increasing parathyroid hormone, which is PTS. That's the body's way of signaling, make more vitamin D and absorb more calcium and phosphorus. So the lower the kidney function in terms of GFR, the more the body will scream and say, make more by increasing the PTH. What does that do? It tends to beat on the bones as it's yelling and leach the bones of calcium and phosphorus. So therefore, if there's not adequate supplementation by diet or vitamin and mineral supplements, then what's going to happen is their bones will become weaker and weaker. And as they progress, the bones can become extremely painful to the point of needing narcotics. I've seen. You and I have a PTH usually less than 65. I've seen over 5,000 in patients in stage 5 kidney disease. So right here, paying attention educationally, nutritionally to the GFR less than 60 is extremely important. Adjustment acceptance happens slowly over time. When you tell someone they have kidney disease the first time, they may not hear anything else that you say in that moment. It's like telling someone that they have cancer. Everything else afterwards is a blur. So again, repetition for learning and retention, asking them to repeat what you said, or act like I'm a student and tell me what I've just told you. The teach back mechanism. It will answer whether they are listening or not, because they won't be able to tell you. And a lot of times they'll say, Doc, I didn't hear a word you say. Some people have even told me, Doc, I'd rather you've told me that I just had a heart attack rather than kidney disease. There's so much stigma, and fright associated with learning that you do have chronic kidney disease, or at least sometimes acute kidney injury, that people really go quiet. They're in shock, and they need to be assured it's not the end of the world. It's not like I've told you your heart is giving out, you need a heart transplant. You can live without kidneys through dialysis, but you can't live without a heart. So it's not as bad as people think, but the morbidity and the mortality increases as the stages go up, all right? So be cognizant, be empathetic that adjustment acceptance happens slowly over time. Access to education may be limited and probably is limited in most cases, especially in your rural communities where specialty services are limited. So start early. Let's not wait to still stage 3 and 4 and 5. Let's target stages much higher, stage 3. Next slide.
Dr. Campbell, could I ask you a quick question?
Sure.
Actually, 2 quick questions. So when we're talking about education, we've been talking about it for the patient. I'm just wondering, knowing that, do you think it's important to make sure that they have someone there with them when you're doing the education, a caregiver or someone else who can hear what you're talking about with the education, just because knowing that, maybe they are a little, suffering a little bit from brain fog, depending upon which stage they're in. I'm just wondering if that would be something that we should advocate for. And then my other question, I was wondering if you could talk a little bit more about pain management when we're getting in those latter stages of chronic kidney disease, just knowing that, I'll have to admit, when you were just talking about that now, you hear a lot of people, sometimes they're suffering from pain, they're thinking it's arthritis and the doctor's not giving me anything for it, when really it's maybe, as you were talking about, more that bone leaching that's happening. So I'm just kind of wondering if you could maybe talk a little bit more about those 2 things.
Sure. First of all, as you mentioned, it's important to have a partner in the room. It doesn't have to be a spouse or a fiance or anything, just any accountability partner, because for shock purposes, even denial purposes, I've had a husband tell me, I told him it was at stage 5. He was referred late, and I said, "You're going to need dialysis." He said, "No, I'm not going to do it." His wife is there crying and so on. But she was instrumental in getting him to see that you can't give up. We're in our 40s. You can't give up. I don't want to be a widow. So had that person not been in the office with me, in the room with me, exam room, I don't know if I could get him to come around. And in the moment, it was very instrumental. Also, again, as I said, it's important for 2 individuals to know what's going on, because if that individual gets sick at home or gets debilitated, it's important for someone else to know the treatment plan and the game plan and to be able to do certain things. That's really important. And two people will receive information differently. And so almost always one partner will ask a clarifying question that will let the other individual know that, oh, you really didn't understand, or you really are not comprehending what the healthcare provider is saying. So I can't stress that enough, that that's important for somebody to accompany the patient on that visit or those visits. Now, in terms of pain management, I always say most doctors are afraid of kidney patients. I've seen some brilliant professors in my time, and once they hear that person has chronic kidney disease, oh, I don't want to deal with that patient. It's important to know, not to panic. It's important to know that there are some pain medicines that you can give to patients who have CKD, whether it's early or advanced. And you can always curbside a nephrologist. With so many resources out there, like Up to Date and so on, you can actually get a hold of resources that will guide you not only in the types of medicines, but the dose reduction issues. Your pharmacist, your local pharmacist, or pharmacists in that hospital, if you're hospital-based, are always willing to help in terms of dose reduction or even the choice of medicines, all right? Non-steroidals are always going to be a no-no. And you know them, Advil, Motrin, whatever you want to call them, naproxen, and so on and so forth. But for example, if one has to be used for whatever life-saving purposes, there are some non-steroidals that are not as harsh as others. And then there are COX-2 inhibitors. We have to be careful with that for the cardiovascular risk. So it's important. It's important to not let the patient suffer from pain that causes so many other things like depression, wanting not to continue in educational classes. So it's important for us to control the pain and also know, why does that patient have pain? It also is important to know, and this is my pet peeve, see everything that happens to a CKD patient is not CKD related. Everybody a lot of times tends to fall into that trap. Oh, it's because of the CKD. Their pain may be due to other things like cancer, arthritis. So they need to get the routine studies that they, that others get. Remember, they have a prostate. They may have a uterus. They have lungs for sure. So, and they certainly have bones, joints, and muscles. And we need to see the patient as a whole, not as a disease. So whenever I would hear my interns or residents say the gallbladder in room so-and-so, I would stop dead in my track and say, don't let me ever hear you refer to a patient as a disease. A patient is a human being that has a disease. That's a big difference. Hopefully I answered your question, Jerry.
Great. Especially that last bit really warmed my heart as a social worker. I'm happy to hear that you let folks know not to refer to that patient as a disease. That's stellar. If we could just listen to that, that's really important. I'm just going to take it from here briefly. We're going to get into our action plans that we had listed over the course of our structured collaborative. As we're here rounding, the end of our time together today, as well as our time together as a collaborative. I just first, before we talk about the action plans, just quickly be able to say to all of you who have participated, whether it was in one session, all sessions, or some of the sessions, we really appreciate the fact that you came through the door. And learning together is so important. Your questions have brought up additional thoughts from our speakers, and then a special thank you to our speakers who brought so many details and brought forward so many things that none of us could really think about at once. So having this go through together has been very helpful, I believe. I want you all to open up your mics and chat in through the chat function. We did offer you these various session action plans. We don't think that they should just sit here on the slide. We're hoping that you're going to take these forward and try them in your practices. They're really good ideas of small tests that could lead to some great change for your practice and especially for your patients. So we highly recommend you take these back to your team and talk through what could maybe be helpful to help your team learn more. Also like to let you know that these sessions are recorded and we're going to have them available to you. And you'll see in the next slide, we have some information as to how to access those. And we hope that you will either go back and re-review or have some of your staff do that. Know that we're also going to be we're going to be seeking you out again. There may be an opportunity, hopefully in the near future, that we'll run this very same 6-session event for whether it's new partners to come through the door or you want to come through it again for whatever reason. But now we'll go back over quick to the action plans. If anyone would have any questions about them, we are at 12:51, so we have a few minutes. But again, please open up your mic, whether you've been here the whole time or just part of the session or part of the 6 sessions. What questions you might have about perhaps having some of these action plans in your organization. Also, Jerry has put in the recordings in our chat. Okay, I'm not hearing any questions. So let us just kind of move to the last slide, because I also wanted to draw attention to some of these other things I talked about in our final thoughts with you. We do and have created a resource link. As you can see at the top there, it's kind of a nice one-stop shop for you to utilize, whether it's, you keep it on your desktop so you can go into it at any given time. Here again, it shows you the session recordings. And most importantly, we really would appreciate you completing the evaluation link so that we can improve this series and also, continue to be better educators as we move along through our work together. Anything you wanted to bring up, Dr. Campbell and Janelle's on the call with us about the action plans that are in place? I can go back to that slide as well. Janelle, maybe just giving you just a quick opportunity to give a final thought here.
Well,
I guess.
Go ahead, Janelle.
Sorry, Dr. Campbell.
No,
I was just going to say, the thing that just rings true to me is the earlier we can get patients identified at risk, the sooner we can start working on that risk and minimizing it for them. And that's true, whether it's their medication choices, their diet, exercise, all of those things are so very important. So please refer as early as you suspect any concern.
And I encourage everyone, thank you, Janelle. I encourage everyone to put a system in place in how you're going to identify CKD patients. And then those ticklers in the system, after you recognize who those or discover who those patients are, what next based on their GFR? And I wanted to leave a couple of things that I purposefully didn't mention because I want them to stay with you. What is CKD? All right. Sometimes that gets lost, so I saved it for the end. Any abnormalities of kidney structure or function greater than 3 months, and one or both of the following must be present for greater than 3 months. GFR less than 60 and markers of kidney damage is important. What are my screening tools? Another critical takeaway, blood work, which include eGFR, lipid panel, CBC, protein creatinine ratio, and albumin creatinine ratio, a urine analysis with a sediment, meaning they spin it and they look at it under a microscope. That can tell you a lot, for example, whether casts are present or not. Know that, again, we said this before, creatinine alone is not adequate or robust enough. When do I refer to a nephrologist? If my GFR is less than 60, significant proteinuria, if the GFR declines greater than 4 mils per minute per year, consult a nephrologist at stage 3 for all patients, regardless of other issues being present. Refer patient to a nephrologist for evaluation again when GFR is less than 30, but we want to realize that we need to co-manage patients with a nephrologist as early as stage 3. Stage 4 and 5, the nephrologist should be definitely taking the wheel over 100%. Know that there are barriers to treatment adherence, family and social support, depression. The majority of patients that come to dialysis, if they end up there, are depressed, but it can start in earlier stages. Income and unemployment concern, support from partners, stress and coping mechanism, cultural barriers, including perceptions of illness and treatment, and limited access to medication and care. I wanted to end there by reiterating those things.
Thank you. Really appreciate it. We do want to also let you know that we're going to be sending you a copy of the slides for each session, since there has been a lot of info in the slide decks. And again, please share those widely. And we encourage you to contact us if you have questions as you review things, as you go through your day or week, or something new comes up for you, because we will relay those questions to our experts that we have within Superior Health and get back to you. So please use us as an ongoing resource. We really appreciate your partnership and think of us as part of your team. So one quick last call for any questions from our audience. Give you an opportunity to unmute.
I just have one quick question.
Go ahead, Amber.
So reading through, obviously I'm playing catch up, and this was all great information. And I think our biggest audience, obviously, is our primary care providers. Is that correct?
Yes.
Yes. So are there, I don't know, suggestions, when you have these very large healthcare systems, right now we've got our dialysis people in on this, and maybe we go to medical director, then medical director goes to the clinics, but to pull these primary care providers in, are there suggestions on that?
Let me just speak to that real quickly and then hand that over to our other experts in the room. Health systems, obviously, as you're talking about, very large. One of the things you could do is go ahead and have some lunch and learns and have someone be the host, standing up front of the room saying, come, we're going to watch this, and then we're going to have someone facilitate a discussion. That's one opportunity. And I did misspeak a little bit. While we really are hoping this will hit providers in primary care, we also hope it hits the rest of the team too, not just the physician. We really want the entire team. So, hoping that you'll share this with social workers and other nutritionists, dietitians, other supporters of the patient within primary care. Would there be something you would add to that? Either Diane or Janelle or Dr. Campbell?
One thing I would say, I agree with you. It's the whole team. Although I'm a little partial to social workers, because social workers usually bring us back to reality in our care planning meeting. Well, that's all good and well, but how are they going to pay for it, doctor? So I think it's really important. The doctors may know a lot about the dialysis and prescription or about the disease process, but when it comes to socioeconomic things and when it comes to nutrition, I don't know what they do now, but we got very little nutrition training in medical school. So I always feel inadequate over the years until I read and dug deeper myself. So it cannot just be the docs, primary care and nephrologists. And it's important that the nephrologist communicates with the primary care and vice versa, so the patients don't get lost in the shuffle.
Thank you. We are at time. So in keeping with respecting everyone's time, we will close. But I do appreciate the audience today. We appreciate all of our speakers on the call. Thank you today, especially to Dr. Campbell, who moderated our last session. This is not the end of this conversation. And please feel free to also write into us more topic areas in this area or even other areas you would like us to cover. And with that, we will thank you and adjourn our session.
Well, Mary, I'd like to say thank you to Jerry, you and Diane for your leadership in all of this. It's a lot of work that goes into this. And I'm just in awe of how you guys pull this all together. And the team that you have that may not be on this call, thank you to them as well. But we appreciate the leadership that you all have demonstrated.
Thank you for saying that. All right. Well, we thank you all. We thank Midwest Kidney Network for being here as well. It's been very helpful, learning so much. So take care. And if you're in the Midwest, go tie things down because it's going to get windy in just a couple hours. All right. Take care, everyone. Bye.